Hi there, and welcome to a video recording for the January 2015 part-time critical care program. I wanted to send you actually a little YouTube video. So Bill's helping me out here in the office with regards to the clinical plans because I've had a couple of questions. It's probably easier for me to explain the paperwork to you on video versus doing it in an email that may be about 20 pages long. So here I go. If you come to this point, you're on the road to clinical, and I used to say to people that you couldn't complain about my cosmetology skills within the ICU when I washed their hair, so you can't really complain about my RT skills now that I'm a nurse educator. But if you've reached this point, that means there's a light at the end of the tunnel, which is my little diagram at the bottom. When we progress into clinical, that means that our programs are performance-based. So to get to performance was at the very bottom. First you have to pass the knowledge, and the knowledge is the stuff that we've been doing. So assignments, exams, and working our way through the theory on NSCC. Many of you have already completed the skills portion, and skills build on knowledge, and that's like your OSCE, so coming up for your physical assessment OSCE, and having to look through the other skills that are integrated in the program. Performance itself builds on the skills and the knowledge, so you have to pass both of those to go into clinical, or the performance portion of the program. And a couple learners have talked to me beforehand about, well, I thought if I pass the exam, I pass the whole program. It's not necessarily that you pass the exams that make you pass the program. It's that you can pass the performance or the competencies at the end. So this is what I'm going to talk to you about today. And performance is actually the clinical portion of the program. So when we talk about clinical, way back in January, I talked to you about clinical models that we'd end up having. We didn't have a lot of information up because we're kind of flexing our models a little bit, and they're going to flex a little bit more in the next year. But for when we started this program, we kind of had three models: a preceptor model, a mentor model, and a challenge model. So a challenge model is for people that are actually ploughing their entire clinical experience. So just like you could plough your knowledge by writing an exam, or ploughing your skills by having your educator or your manager say, I do these every day in the clinical area, you could come up and do a simulation. You could actually plough your clinical portion as well, so you could plough the entire program. Nobody's really applied for the challenge model, so I'm not going to talk about that one at all. And you're going to see how I flex the wording here. So the mentor model, now I'm calling it preceptor mentor, which means that you're with a preceptor, but you're not coming out of your role at the bedside. The straight preceptor model, the people that would qualify for that are the ones that are not currently working in the ICU, and the ICU is going to be a new experience for them. So they go in, get buddied up with a preceptor, and the preceptor is in charge of the patient, and they build themselves up to providing independent and consistent care for the patient at the bedside by the end of the clinical experience. In the mentor model, you don't come out of your own role, so it's for people that are off orientation, working currently in the clinical area, and that have applied for the mentor model and are suitable for that mentor preceptor model. So let's get to the paperwork and what's life like without a lot of paperwork, because I feel like I'm totally killing the Amazon forest here, but we're going to talk about the paperwork for all of these. So when I talked about the paperwork, I really had to look at what do you guys currently have already, and I went online in NSCC and looked at what we had printed off for you at the start of the program to make sure that I had that correct. So when I did that, this sheet should look familiar to you, and it's the summary skills checklist. And the summary skills checklist is your skills that get signed off in the lab. So they should be signed off as being passed or failed, or whether you ended up ploughing them. And this sheet should all be filled out from your skills already. But the second portion of this is a portion that we use in clinical. This is what's called the repeat exposures. And when I look at this, it's all the skills listed down on the left, and it's in columns, and each of these columns is a day. So when you get to clinical, your preceptor initials the columns on the skills that you've performed. So you've done repeat exposures to them. So at minimum, you'd be doing an assessment, and you'd probably have the patient on cardiac monitoring. And then depending on whether the patient was ventilated or whether they needed to have withdrawal of specimens from an arterial line, you'd get your preceptor to be able to initial it. This sheet, along with the summary skills checklist, the sheets here come in at the end of clinical. And I recommend that people make a photocopy of these themselves and keep it in their own professional file, because you can say, in 2015, I completed the critical care nursing program. These were the skills that were in the program. These were the repeat exposures that I had. It's a good idea to keep track of that in case you end up someplace where you're not currently working. You would have a record of things that you ended up doing in it. The other piece of clinical documentation that you guys have is what's called the clinical competency document and learning plan. So remember I said that performance needs to be passed when you pass our competency areas in the program. We've been building up to that through knowledge and skills. Everything that you have is dated with your name on it. the first page is looking at what unit you are doing your shifts in, and the next page is looking at the competencies within the program. And the big competency in our program is patient-centered care, and that means that you can independently and consistently provide care for a stable, predictable patient at the end of your clinical shifts. So what I mean by that, by stability and predictability, I'm going to talk to you a little bit more about those wording, is that we don't want to have you going into clinical and looking after the sickest of the sick patient. We want you to be able to look after a patient that's suitable to where you are within the ICU. The other competency areas that you would need to be signed off on are teamwork and collaboration, quality improvement as an evidence-informed practice, safety, and informatics. And the performance criteria is listed in here. And what your preceptor does is initials them off as being satisfactory or unsatisfactory. The next page of this clinical documentation is what is called your clinical learning plan. This is completed before you go into clinical. You develop it having a listing of your strengths. So what am I really good at right now? What am I bringing into the clinical area? Like, for instance, I'm an effective communicator. I have great teamwork and collaboration skills. I'm organized. I have effective time management skills. I already know how to look after this kind of patient. And then you developed areas for improvement. So I know how to look after this stability of a patient, but then I want to be able to look after, I don't know, a post-arrest patient. So you make a SMART goal specific to that, and then look at strategies for how you're going to be able to achieve that goal. You do up at least 3 goals and then submit them to faculty for review. If you're in the mentor model, you actually review them as well with your manager, your educator, and your mentor/preceptor, so that everyone's clear about what your goals are when you go into clinical, because it's hard to have a goal, like say for mechanical ventilation, if you never look after a patient who is mechanically ventilated. And that kind of makes sense. So like, for instance, for people who, I don't know, say work in, let's use an example, St. Martha's Hospital. St. Martha's Hospital currently doesn't use pulmonary artery catheters. So if you made a SMART goal that you were going to be independently and consistently looking after a patient who had pulmonary artery catheter management, that wouldn't be possible there because you don't actually have pulmonary artery catheters. So they have to be realistic to be able to be achieved in your clinical area. This last column is called feedback, and that's where you reflect upon your goals after you're done clinical. So just leave this last column blank. Fill out your 3 goals with strategies to be able to have them. And we gave you an example, and I'll show you that. And I am absolutely fine with copy and paste. Do not reinvent the wheel. It's an example on mechanical ventilation that learners commonly have when they get to the performance portion of the clinical. The other thing that they commonly end up using is medications. They'll often say, you know, like, there's all these vasoactive medications that I'm unfamiliar with, and I need to make a SMART goal that is achievable so that I can introduce myself to more of them. So we have a few columns in here, and we say a minimum 3. I usually like to caution learners to limit them to about 5 because you have 14 12-hour clinical shifts in the preceptor model, and if you have 12 goals, it's going to be hard to be able to achieve all of those at the same time. That gets submitted to us the end of August, and we give you feedback on it. The other thing that you're going to see in this document is the preceptor-to-preceptor communication tool, and that is if you had 2 preceptors within clinical. Once you're done with one preceptor, you could have that preceptor fill this out. This is what the student's been doing so far. This is what they're strong on so far. Here's some areas of improvement that they may end up having, so that you have a consistent way of giving feedback between the preceptors to continue your clinical on. The next page in this is actual comments. So you should have some comments on your performance or clinical competency document from preceptors, mentors, your own comments on reflections that you've had from your clinical experiences, and faculty's comments that you end up having. And if faculty does a telephone meeting, what they end up doing is typing up notes from that conversation, and they'll attach it to the back of your clinical competency document to go on your file. The last piece of this is your final learning plan. So you develop a learning plan before clinical with 3 to 5 specific goals that you're going to achieve within those 14 clinical shifts. At the end, you reflect on how you did on those goals, and then you develop a new learning plan, which gets submitted at the end of clinical. The new learning plan should be made up of new goals, and I word it that way because you don't just take the learning plan that you develop for clinical and transfer it over. if you did that, your goals wouldn't have been SMART at the first part of it because they weren't specific, measurable, achievable, or realistic, or even timely because you didn't get to them. Now, there may be some components of that you weren't able to actually finish that you want to bring forward to this last learning plan, which is perfectly fine. I just caution learners, I don't want to see the exact same learning plan because it's kind of lazy, actually. This learning plan that comes in here will have these initial columns filled out. And what it is a learning plan for transition back into practice. This is a format the college is actually going to, and it's part of your continuing competency plan. So like when you go to tick that box off for your license in the fall, you're going to have all this information already done. So you're going to make a plan for during clinical, and then you're going to make a plan for after clinical. And when you submit it, what's going to happen is Bill, our wonderful administrative support person, is going to be able to take this, scan it, and then he's going to email it back to you, your manager, and your educator and say, they've done this program, they've developed this learning plan afterwards, and these are their goals for after they're through on clinical. And then you can have a conversation with your manager and educator about your strategies and how you're going to achieve your goals in your next little bit. And it should be a stepping stone for you to have a performance appraisal done. So that is your clinical competency document. So for clinical paperwork, you need to have this summary skills checklist with repeat exposures and this clinical competency document. I talked to you about SMART goals and how that there was an sample in you. You're going to see this document that's loaded up on NSCC and has been for a while. And there's an example of a SMART goal that I've talked about, which is one on mechanical ventilation. And it talks about what the SMART goal is, and it talks about the strategies. This little piece here on feedback is something that you need to be able to think about, but don't reflect on it yet because the reflection piece comes at the end of clinical. Okay, so those are the documents that you currently have. So what's new with regards to clinical documentation? There's two new things that I'm going to show you, and one of them is called a clinical log. And a clinical log is just a record of what kind of patients that you've taken care of in your clinical experience. So each of these rows is a separate patient that you're going to end up having. And I know this is super duper small, but it talks about date and then the age, gender, income, education, social supports, home and or work environment, and health and coping behaviors of the patient. And we talk about that because we really want to make sure that our nurses are looking at the social determinants of health of our patients, which very much affects how patients are admitted into the ICU. And then it talks about diagnosis and any problems that they may have in our conceptual areas that we've talked about in ventilation and oxygenation, pumping or perfusion, inflammation or consciousness. And then there's a column on patient status. And do you remember how I mentioned the words predictable and stable? That's the wording that we want you to be able to use. So whether the patient is stable, predictable, complex, or has a high risk of negative outcomes. And that wording's really come out of a document that was produced by the College of Licensed Practical Nurses and the College of Registered Nurses in Nova Scotia. It's on page 12 and it talks about complexity of the patient. So a patient who is very complex is somebody who's having multi-system organ failure. So it's every system that's affected. Whereas a patient who doesn't have a lot of complexity might be somebody who is admitted for pneumonia, has no other medical history, and is just on some mechanical ventilation, getting some antibiotics, and then going to go home. Predictability means how predictable the patient's going to be. So if they're unstable or they turn very quickly, that's what I mean by predictability. And the risk of negative outcomes is the risk for the patient that they're going to end up having. So for instance, if you were admitting a patient with post-arrest, their risk for negative outcomes would probably be very high because depending on their neurological status, when they achieve ROSC, it may be quite high versus someone who is admitted, say, with, urosepsis, that they identify an organism right away, get them on the appropriate antibiotics, and they usually turn the corner very quickly and get better quite quickly. So there's not as much risk for negative outcomes. I'm hoping that kind of makes sense. So the daily logs, the clinical daily logs get completed every day in clinical, and then it says at the bottom of it, email them or fax them to faculty at the end of the program with your clinical documentation. The other piece that's going to be new to you guys is what's called a reflective journal, and I'm sure that everyone's very familiar with reflecting. And what we want you to be able to do with this journal, it's short, 2 pages. There's a little rubric at the end of it. We want you to be able to reflect on a good experience and a not so good experience and what you've learned from that. And I'll send all this documentation out to you along with this video so that you can end up seeing, actually Bill's going to do it for me once the video is loaded up onto YouTube. And you can be able to see this. If you have any questions at all about the reflective journal, you can contact us. We put the due date on the reflective journal assignment for after the 8th clinical shift, so before you're ending up done, but right in the middle of clinical. So you should have had a good experience and a not so good experience hopefully by then. Hopefully not too many not so good experiences. I'm hoping it's all really good for each of you. The next little bit that I want to do is talk to you about the preceptor model and the preceptor mentor model, so what the paperwork is specifically for that. So the first one I want to do is the preceptor model. And the preceptor model means, as I said, you're not currently working in the ICU and you're going to be buddied up with a preceptor for your 14 clinical shifts. There's clinical guidelines for the preceptor model. You guys have this. It's online on NSCC. It's in your program manual. And it is on page 15 to page 17. And it goes through guidelines. So like you're going to be assigned to a preceptor or buddy. You need to develop a learning plan with SMART goals. It is an expectation that you have an open discussion with your preceptor about where you are within your practice. And we talk about that because that's a safety mechanism for our students when they're going into clinical. So for instance, if you've gone into clinical and you've never given an IV push med before, now is not the time to suddenly say that you have 2 6-gun shooters on the side of your belt saying that you're going into clinical for CCNP and going to give everything by IV push. You need to be honest about that and say, I've never given that before. Can you talk to me about the learning module and the policy for that, and build yourself up to it. It talks about all the do's and don'ts for medications, verbal orders. You need to read this before you go into clinical, and I'll give you the page numbers when I send it out to you. And the other thing that is in the preceptor model is a clinical discussion guideline. So I'll send this out to you. And basically it's like a little way that faculty uses when they have a visit or a call with you. So we'll either call you or visit you and have a discussion about your patient. It's kind of like a little report, really. You talk about the patient's history and their presenting problem, what their assessment findings are that you've done. Look at their EKG, their gas, their lab, their diagnostics. Talk about medications that they end up having, then look at what your plan of care is for that patient. And through that whole conversation, faculty will weave into the theoretical components and really try and help you apply those concepts. And then it gives you a little tiny bit about evaluating the experience. It's not meant to be a grill. This is just like a shell of how we would like you guys to be able to present this from your patient. So whether it's when we visit you or whether we call you, that's what we want you to be able to talk to us about. So that's preceptor. Have a look through the program manual with the guidelines, and then look at the clinical discussion ones. And please know that we don't call you on the first shift, because that would be just rotten to anyone. We would never do that to anybody. We hope that you have a great clinical experience. That's paperwork for that. The mentor model paperwork, there's a lot of papers for it, but it's good papers because it really looks at making this a valuable model and a valuable learning experience for people. So the first thing that's in the mentor model paperwork is guidelines. So very similar to those guidelines for the preceptor model, there's guidelines for that preceptor and mentor model. And the guidelines for this is really having a relationship with the person that you're buddied up with. And by that I mean that you want to choose your preceptor mentor wisely, because they're the ones that are going to be evaluating you on the clinical competencies, and they're the ones that are going to be working with you regarding your learning plan and making your goals. You want to make sure that they have a good understanding of what their roles are, and you have a good understanding of what your roles are when you go into this relationship. And the other thing is that you need to have this model approved by your manager and your educator. I've talked to you about who it's suitable for, and you can have a read through the document. It's very clear and very well laid out. That's the first document. The second document is the actual application to the mentor or preceptor model. So if you decided that this was the model that was right for you, you're independent in practice, you're off orientation, and you're going to look at this model, you would have your manager or educator sign you off and make sure that you're suitable for this so that it's approved by them. And then you would talk about who you were going to pick for a mentor or a preceptor. This next little document that's going to be attached to this is expectations, and this is something really good to be able to read through yourself as the learner. So there's learner expectations and there's expectations for the preceptor and mentor. And the expectation for the preceptor and mentor really gives ones that have not served as a mentor or preceptor in our program before what we mean when we talk about this kind of model. So it talks about having a relationship with them, having an agreement, discussing what exactly is going to go on with clinical, sharing your SMART goals with your preceptor and mentor, making sure that the preceptor mentor provides you with guidance, assesses them, you can seek out assistant, facilitate. All of those items are listed in here, and you need to read through that and share that with your preceptor and mentor. Once you've shared that and your learning plan, you should come up with an agreement yourself, like how we're going to meet, how long, what those conversations are going to look like, what the shifts are, and then have that signed by your preceptor and mentor and your learner, and making sure that you have contact information so that even when you're not working in clinical, you can have a conversation with them to say, like, I don't know if this really worked well, because you're both going to be busy with an independent patient assignment. So there's going to be some assessment, but you're going to have some time to be able to talk to one another as well about how clinical's going. The last little piece of it is actually the clinical case study guidelines. So when you're in the mentor or preceptor model, we're going to have a similar case study or patient presentation. So following your 6th shift, you're going to select a patient within those 6 shifts and verbally present them to faculty for an assessment. And this is going to be done at a mutually agreeable time. So email your faculty and say, hey, I'm done my 6th shift within this time. Do you have time to be able to meet between here and here? I'd like to be able to do my presentation. And the reason I say, do you have time to be able to meet between here and here, is that there's just Kelly and I in the office and we're running a full-time program at the same time. So it's important to find a mutually agreeable time. And we don't want to do this while you're actually working, because you're actually caring for an independent assignment yourself. And oftentimes the learners really do find it's nice to be able to sit back, reflect on the care that they've provided for their patients, and then have a look at presenting the assignment. The assignment guidelines are here, and it's very similar to the ones that we would have with the discussion. So what's the patient's history, presenting problem, what your physical assessment findings were, EKG, ABG, what your patient priorities were, what was your plan of care, how did you integrate the theory from that, and then evaluate the experience yourself. So that's the mentor model in a nutshell. Sure, a nutshell, because this has gone on long enough, hasn't it? And here's what I always do at the end of every teaching session that I have. What do I need to take out of this? Like, what are the Coles Notes versions for what I need to be able to take out of this for clinical? So here it is. This is what I want you guys to be able to do. Figure out what model you're taking. Is it preceptor or is it mentor? If it's mentor, you need to be able to apply it. If you're really unsure, you need to email us. If it's preceptor, faculty's going to find your preceptor, and we pretty much have a good idea who's in the preceptor model yourself, because we know who has ICU experience and who doesn't have ICU experience. So we're going to be talking to the managers and the educators about where you do your clinical, and you're doing your clinical in your home site. You should be developing a learning plan and submitting that learning plan with a goal specific for you, for what you want to be able to achieve in clinicals, because we want to make this as personal as possible. Faculty will send you the preceptor's name and the contact information, and once you submit your goals as per the study schedule, they'll send you some feedback on your goals. If you're in the mentor-preceptor model, you need to apply for that model if that's what you want. You need to figure out who your mentor-preceptor is going to be. You need to get that approved by your manager and have the documentation signed, as I've talked about it. You also need to have some learning plan development specifically for the mentor model, and you need to email the faculty the shifts that you're going to be designating as clinical shifts after the exam. Here's the final step. Sit back, relax, and enjoy the sun. I'm going on 2 weeks vacation. You guys are supposed to be on study break. I'll see you all later, and if you have any questions about anything, don't hesitate to call us.